Health Committee informational hearing. This meeting is going to be shown on CTN, and it is also going to be on YouTube as well. So just be aware that you are live. I'm Senator Saud Anwar. I'm honored to be here this morning, and I am going to first yield to my honorable co-chair, Representative Steinberg, for initial comments. Thank you. Representative Steinberg.
Thank you, Senator Anwar. Good morning to everyone. As you can see, I am not in the Capitol. I also want to get clear, I'm not driving, but I am returning from a conference and will participate on this informational forum via the phone. All I really need to say, I believe, is that we recognize monkeypox has come to Connecticut. I'm actually getting a little bit worried that maybe soon we'll have polio coming to Connecticut. But right now, the best thing we can do for protecting the public health is to keep everybody informed and to put it in perspective. To some degree, our ability to combat this will be dictated by the amount of vaccine that's available, which is still in short supply. But being knowledgeable about how monkeypox is transmitted and what one can do about it is critical for people to have peace of mind and to do the right thing. And I'm confident that today's public informational forum will provide that kind of background for people and lead them in the right direction. Back to you, Senator Anwar.
Thank you so much, Representative Steinberg. And I wanted to apologize to Representative Steinberg as we were trying to coordinate the time for this meeting. He had this previously scheduled conference, and we were not able to navigate our time as well as we could have, but that we felt the timeline was critical to get the word out and have the conversation in advance. So I wanted to say a few things about why we are here, what we are going to hopefully be able to achieve. I wanted to start by saying that on the 23rd of July, 2022, the Director General of WHO, Dr. Tedros Adhanom Ghebreyesus, he declared a public health emergency of international concern. This was a situation where this public health emergency was declared globally because there were 70 countries, which are non-endemic because the disease monkeypox is endemic in Central and West Africa parts of the two countries. And this was actually outside of that region. It became very common and it was sporadic, and there were no clear epidemiologic links that were identified. And at that time, the WHO had recognized that the window to control this was going to be very short. And if we can get all hands on deck and we had a global effort, we may be able to control this in a better way. So that's what the rationale was. Back in August 4th of this year, 2022, United States also declared it as a public health emergency. And as of yesterday, globally, we have had over 38,000 cases worldwide, with about 12 deaths that have been recognized related to monkeypox. And in the United States, as of yesterday, there were 12,688 cases, with thankfully no deaths associated with them. Basically, 1/3 of all cases in the world that have been identified are in the United States. Within the United States, we know that New York and New York City have been at the forefront again to get the brunt of a lot of the infection. Initially, there were proportionately almost 1/3 of all cases in the United States were in New York City, but now the numbers are decreased, which means that other parts of the country have many cases as well. So as of recently, 2,295 cases were in New York. And we will probably hear from DPH about the Connecticut cases, but my reading is there were 69 cases as of yesterday. So as we look at this, we are all somewhat traumatized by the last 3 years. We have all experienced COVID and its various manifestations, how it has impacted our lives. So there is this a community-wide post-traumatic stress that we have been experiencing, that, oh my God, we have another infection now. And then it's important to recognize that if we are organized, if we are coordinated, we have an opportunity to prevent things from getting worse. And that's what public health is about. That's what coordination, collaboration is about. And that's why this is critical for us to come together and have conversation around this area. And I wanted to start by saying that this is not COVID. This is not spread by aerosol transmission. And this is not, thankfully, not as deadly as COVID has been in the last 3 years or so. So that's important to recognize. Now, as we move towards our conversation, we are blessed to have a number of people who are going to be able to help guide us. And by the end of our conversation and session, with all the questions and discussions, we should be able to get a better handle about the illness itself, but also a better health understanding of where we are as a state and what are the areas of opportunity and how we can collaborate better in some of those areas. So we will have our presentation with the Department of Public Health, which is here with Miriam Miller, Dr. Lynn Sousa, Jamie Kresnitsky, Sydney Jones. And then we also have other presenters who would include representatives from Connecticut Health Hospital Association with Brian Cornoyer and Karen Buckley and Dr. Asha Shah, who's a director of infectious disease and hospital epidemiologist for Stamford Hospital. And we have representation from Connecticut State Medical Society with Mike Johnson and Dr. Michael Virata, who's an infectious disease specialist affiliated with Yale New Haven Hospital as well. And then we are also thankful to have Dr. Linda Estabrook, who is part of the Hartford Gay and Lesbian Health Collective. And I wanted to thank Dr. Estabrook for collaborating and coordinating with DPH and DCP to make sure that we are doing the best we can for our state. So with that, I will hand it off to Department of Public Health for giving us the initial presentation, and we'll have other people weigh in. Thank you so much for DPH for your leadership, and thank you for being part of this conversation today.
Thank you, Senator. All right, I cannot share my screen.
We'll fix that shortly.
Sure.
Try now.
Okay. Yes. Okay. Can you see my slides?
Yes.
Excellent. Thank you. All right. So thank you, Senator. I am Dr. Lynn Sousa. I'm the acting state epidemiologist and director of infectious diseases here at the Department of Public Health. And I wanted to take the opportunity today to thank you for having us. And I want to just go over and hit all of the points that you have already done in your introduction today. So we wanted to talk about monkeypox, what it is and who it is affecting. How a person who thinks they have monkeypox can get tested, talk about the treatments for monkeypox, as well as discuss the vaccine and the vaccine network that has been established in Connecticut. So as Dr. Anwar mentioned, monkeypox is not a new disease. However, until this current outbreak, it was relatively rare. It is endemic in West and Central Africa. It's caused by the monkeypox virus. And while it is not specifically known what animal reservoir it lives in, it is likely small mammals. And prior to the current outbreak, it was spread either from infected animals to humans as well as person to person. And that included respiratory secretions, skin to skin contact, as well as fomites. So items like shared items like towels and bedding. The incubation period, or basically the time that it takes for someone to get sick if they are exposed, is certainly longer than COVID, an average of 5 to 13 days. A difference from COVID, which is good, is that a person is not considered contagious until they have symptoms. So right now, we're not concerned about people who are exposed who are not yet sick. And our experience in the United States with monkeypox prior to the current outbreak was related to people who were traveling or importation of small mammals. So starting in May of this year, we started hearing of reports of large numbers of cases of monkeypox, first in European countries where monkeypox does not usually occur. And the cases were associated with attendance at large parties and raves. And it was primarily affecting men who have sex with men, bisexual men, and other men who have sex with men. And the difference between our previous experience with monkeypox is that people were primarily contracting it through skin-to-skin contact, including close, intimate, and sexual contact. At this point, there's already 32,000, almost 32,000 cases in 89 countries. And as of last month, it has been declared a global health emergency. Monkeypox in the United States, as Dr. Anwar said, New York City has been the epicenter of the current outbreak, almost 13,000 cases in the country. And based on an MMWR that was released a couple of weeks ago, the median age of persons affected is 35 years, with almost everybody identifying as male sex at birth, and the majority being men who have sex with men. The racial ethnic breakdown of persons affected, about 40% white non-Hispanic, 28% Hispanic, and 26% Black. There have been 2 cases in children in the United States so far, but there have been no deaths, thankfully. In Connecticut, we have had 69 cases reported as of yesterday. And also as of yesterday, we have posted these data on our monkeypox website, and that data will be updated every week on Tuesdays. So our first case in Connecticut was reported the first week of July. And as you can see here, we are averaging about 10 to 12 cases every week. Similar to the national data, almost all of our cases are in men and among persons who identify as LGBTQ+. Our median age is 34 years, with most people being between the ages of 20-49. And 7 of our counties have reported cases. And you can see the racial ethnic breakdown here as well. Again, similar to what we are seeing nationally. So I'm not going to go into a lot of pictures about monkeypox, but I did want to show what it looks like. So I will say that monkeypox, the rash does go through stages. Some people, before they have the rash, will have what we call a prodromal illness. So basically a flu-like illness. They could have cough, sore throat, fever, feeling tired, and then the rash will come. We have learned with this current outbreak that sometimes people, that will not happen and they will just have a rash. This is kind of what the classic monkeypox rash looks like. However, there are different stages and it can look like other things. It can look more vesicular, like a chicken pox or a herpes or something like that. And so it is, we have been working really hard to make sure that healthcare providers know about what it can look like. And it is also important to know that right now, a person cannot be tested unless they have a rash. So in Connecticut and generally, we have been working really hard to make sure that any healthcare provider in the state can test a patient for monkeypox. As I mentioned, somebody does need to have a rash to be tested, but even if they just have one lesion, that is sufficient to do a test. The healthcare provider would swab the lesion and send it to the laboratory, and then those results come back to the healthcare provider to give to the patient. The State Public Health Laboratory in Rocky Hill was the first laboratory to offer monkeypox testing for Connecticut residents, and they continue to do so. As of August 12th, the state lab has tested 468 swabs from 233 patients. And they started on May 22nd with that testing. Their testing at this point is primarily Monday through Friday. However, they will do urgent testing, and they have done that with great success. And their turnaround time continues to be very fast, generally 24 to 48 hours. I will mention that as of July, there are 5 commercial laboratories also offering testing for monkeypox. That includes Quest and LabCorp, which do serve a lot of healthcare providers in the state. And again, with the message being that any healthcare provider should be able to test a patient for monkeypox. The State Public Health Laboratory will support getting specimens to the State Public Health Laboratory for those facilities who do not otherwise have the ability to do that. And there has also been a lot of education, not just for healthcare providers in terms of making sure that specimen collection information is available on our website, but also actually providing specimen collection supplies to healthcare providers that need it, as well as working and providing guidance to laboratories in the state in this regard. So just some general guidance about what someone should do if they have monkeypox. So once somebody is sick with monkeypox, unfortunately, it can take a long time for that rash to resolve. It can generally take 2 to 4 weeks. And so the recommendation is that somebody isolates until that rash is fully resolved, meaning the scabs of those lesions have fallen off and a fresh layer of intact skin has formed. So ideally during this time, people are staying home, except certainly if they need to have follow-up care or emergency care, and avoiding close contact with others. That includes wearing a mask if they have to be in close contact with others in the home, and not engaging in sexual activity or other activities that require direct close contact. This includes not sharing potentially contaminated items. So those fomites that I mentioned, things where the virus could live and get transferred to somebody else. And then also advising people not to have close contact with their pets or other animals in the home. But even before somebody gets sick with monkeypox, there are things that people can do to protect themselves and hopefully decrease their chances of getting monkeypox. That includes being aware of a new or unexplained rash either on their body or a partner's body, including in the genitals, seeing their healthcare provider if they're sick or they think they might be sick, or certainly especially if they have that new or unexplained rash. Avoiding close skin-to-skin contact with people that have a rash that could be monkeypox. And that includes not just not having sex, but not touching those lesions, not kissing or hugging or cuddling somebody, not sharing those eating utensils or other bedding that someone could have. We've gotten a lot of questions about condoms, and condoms certainly may help in preventing exposure to monkeypox, especially if that rash or sores are in the genital area. But we don't think at this time that condoms alone are enough to prevent monkeypox. So it is important to have that layered approach. And certainly considering limitation of the number of sexual partners could help reduce the possibility of exposure to monkeypox. So regarding treatment for monkeypox, so we are fortunate that there is a treatment. It's called tecovirimat or TPOXX. That was an antiviral that was developed to treat smallpox, but it can be used for monkeypox. And so far in Connecticut, 25 patients have been treated with TPOXX. The considerations for using TPOXX, including for persons who have severe disease, and this includes bleeding or severe pain. Unfortunately, the lesions and the rash for monkeypox can be quite painful, as well as persons at high risk of severe disease. And that includes people with certain skin conditions, as well as persons who are immunocompromised, including people with HIV. A limitation of TPOXX is that it is an investigational drug. So there is a protocol that must be followed, and that includes people needing to provide informed consent prior to starting the medication. There has been a lot of advances over the last several weeks on the CDC and FDA side to make this process much easier for healthcare providers. In addition, in Connecticut, we have worked hard with CDC to make sure that TPOXX is available in the state, both at multiple hospital systems, as well as through the UCHC specialty pharmacy, so that providers can easily and quickly request TPOXX for patients. And most of our patients have been outpatients. So we've worked really hard to make sure that TPOXX is available in the state, and that is not a barrier to obtaining medication for patients. So let me talk a little bit about vaccines for monkeypox. So there are 2 vaccines. The main one, and the one that everyone has heard about, is the Jynneos vaccine. And this is the vaccine that is currently being allocated to Connecticut by the federal government. As mentioned, it is in limited supply. However, just recently, the FDA issued an emergency use authorization that updates the administration of this vaccine. So prior to last week, the vaccine could only be administered subcutaneously. It can now be administered intradermally, And the benefit of this is that it increases the amount of vaccine available because it is a lower dose that is required for an intradermal administration. This vaccine does have a live virus. It's the vaccinia virus, but you cannot get monkeypox from this vaccine. The virus is not able to replicate. This is a 2-dose vaccine administered 4 weeks apart, and a person is considered fully immunized 14 days after the second dose. The effectiveness of this vaccine against monkeypox is supported by animal studies. The adverse reactions are generally localized to the injection site, including pain, swelling, and redness. And this vaccine is safe for administration to people who have HIV as well as atopic dermatitis. The other vaccine that can be used is called ACAM 2000. This vaccine, while is more available, is actually not currently being used, but we are talking about it because it is something that will be exploring. So that there are additional considerations in terms of using this vaccine. So this is a vaccine that people might recall. It was licensed for use against smallpox and was, I believe, the vaccine or a form of it was used in the early 2000s when people were being vaccinated against smallpox in response to 9/11 and bioterrorism attacks then. The difference between Jynneos and ACAM is that the ACAM 2000 vaccine is a live vaccinia virus, and it is administered in a special way. So it's percutaneous, and it requires actually a special needle and a special process for which a provider needs to be specially trained. And to kind of know that the vaccine worked, you're actually looking for a lesion to form at the site of that vaccination. This is a 1-dose vaccine, but it does take 4 weeks for that immune response to be mounted. And actually right now, because it is licensed specifically for smallpox, it can be used against monkeypox, but again, is considered an investigational use and requires informed consent and an additional protocol. Its effectiveness is supported by both human and animal trials. And this vaccine does have many more potential adverse reactions that have to be monitored. And it cannot be given to as many people. It cannot be given to persons who are immunocompromised, including anybody with HIV, as well as several certain medical conditions. So I wanted to talk a little bit about the monkeypox vaccine timeline and how vaccine got to Connecticut. Prior to June 28th, we were able to obtain the Jynneos vaccine for persons in Connecticut that were considered close contacts. And so we've been able to do that since the end of May and beginning of June. On June 28th, the federal government announced that there would be a federal allocation process for the monkeypox vaccine to local jurisdictions. And they announced that there would be different phases to this approach. So on that day, phase 1 was announced, and Connecticut received 0 doses in that phase, primarily because we did not have any cases at that point. The other thing to keep in mind is that on June 28th, a phased approach and the timeline for that approach was announced, but that timeline has changed drastically over the coming weeks. So originally we were told that phase 2 would come at the end of July and phase 3 would be at the end of August. And that has clearly been accelerated, which is a good thing. So unexpectedly on July 8th, we heard about our phase 2A allocation, which was 635 doses. And then the following week on July 15th, a phase 2B allocation of 1,143 doses. So while this was all happening, we were working to make sure that we had a vaccine network established in Connecticut so that we would be able to deliver a vaccine. We were able to get all of the available vaccine doses at that time delivered to 4 hospital depots in Connecticut on July 22nd. And began distributing it to, at that time, 15 community clinics to make sure that we could ensure rapid access to vaccine for especially close contacts of persons to monkeypox. And then as of August 1st, we were able to implement an expanded PEP++ approach, which I'll talk about in a minute. And also on that day, we learned about the accelerated phase 3 allocation when we were able to order 1,820 doses. And then just early this week, we learned that we were able to access the rest of our phase 3 allocation, which was 2,700 doses. So how can monkeypox vaccine be used? And so there are really kind of three strategies for using monkeypox vaccine. The first is for post-exposure prophylaxis. So that's for persons where there's been a known exposure to somebody with monkeypox. When using it as post-exposure prophylaxis, it can be given up to 14 days after exposure to prevent illness, but really it is best used within 4 days to maximize actually preventing illness. From 5 to 14 days, what we're really doing is mitigating any illness that somebody could have. And the idea here is that public health facilitates these referrals to make sure that these persons with known contact are prioritized for vaccine. The next strategy is called expanded post-exposure prophylaxis, or also PEP++. And the idea here is to identify persons with risk factors for exposure to monkeypox. And again, trying to identify people that might have been exposed, but don't necessarily know for sure that they've been exposed, and trying to get those folks vaccinated. And then finally, there's pre-exposure prophylaxis, which could be used for somebody who is at high risk for exposure. In this case, that has been used for persons working in the laboratory and processing monkeypox specimens, but is not recommended for most people at this time. So in Connecticut, as I mentioned, we have been offering vaccine as part of post-exposure prophylaxis since the beginning of the outbreak. And then as of August 1st, we did implement that PEP++ criteria. And as of today, we are actually slightly updating that criteria. So again, our number one priority is making sure that persons that are identified as close contacts to someone with monkeypox are able to access vaccine as quickly as possible. And then we are updating the criteria for PEP++ to make it a little bit more flexible. But also we had heard that some of the language was considered stigmatizing. We wanted to make sure that people knew that if they fall into this criteria, we want people to certainly access this vaccine. And so this change also aligns our criteria with the states around us, and especially Massachusetts, as well as the CDC wording. So the criteria as of today for PEP++, so that's includes people who are aware that they had a sexual partner in the past 14 days that was diagnosed with monkeypox, or had multiple sexual partners in the past 14 days in a jurisdiction with known monkeypox. The vaccine for this situation is still only able to be offered to persons who are 18 years of age or older and are Connecticut residents. However, if somebody meets these criteria and is also somebody who definitely knows they were in contact with somebody with monkeypox, somebody that is meeting partners or part of social networks that could have monkeypox, or at increased risk for severe disease, are definitely people that we want to make sure get vaccinated. However, people who have had monkeypox or currently have monkeypox are likely going to have protection against another infection. And so those folks are not currently eligible to be vaccinated. So if somebody has already had monkeypox, they are not eligible to be vaccinated at this time. So far, we are up to 20 clinics in our network, and we are very thankful for these clinics for partnering with us. We have administered 1,710 doses of the Jynneos vaccine by Connecticut providers as of Monday. And the circles here show the clinics that have offered more vaccine. The smaller circles are really indicative of clinics that have come online more recently, and not necessarily clinics that are offering less vaccine. In regards to who has been getting vaccine, so far, 1,802 Connecticut residents have received at least one dose. You'll see that is different than the 1,700 number I just showed in terms of number of doses. We are able to receive information from our surrounding states of Connecticut residents who were vaccinated in Rhode Island and New York City. And so this number here reflects those Connecticut residents that were vaccinated, even if it was outside of Connecticut. And you can see here that most of the doses have been provided to persons that live in New Haven, Fairfield, and Hartford counties. And here you can also see the racial ethnic breakdown of the persons who have received vaccine. And again, these data are also now available on our monkeypox website and will be updated every Tuesday along with our case data. So in summary, we have been working hard at DPH to provide regular updated information to our healthcare providers, our laboratories, as well as the public through our regular communications, memos, webinars, as well as our monkeypox website. Our state public health laboratory was the first laboratory to offer testing in late May and continues to offer rapid turnaround testing in Connecticut, along with 5 commercial laboratories. We have been facilitating rapid access to TPOXX by making sure that it is available physically in the state, so that it is not a barrier to access. And we've established a network of clinics to ensure rapid access to vaccine for eligible persons in Connecticut. So thank you for giving me the opportunity to talk today.
Thank you so much, Dr. Sosa, for the presentation. Dr. Sosa, what we will, I'm sure a lot of us have a lot of questions, but I do have other people who are going to present as well. So the thought was that many of those questions may potentially be answered in the during the course of our conversation. So I will hold the questions for the time being, and as soon as everybody who's here to speak have had a moment to share their perspective, then I'm looking forward to some questions myself, and I'm sure the Public Health Committee members will do the same. With that, the next person on our list to speak is Ms. Linda Estabrook. Linda Estabrook is an advocate for the LGBTQ+ community for more than 30 years. She's the executive director and co-founder of the Hartford Gay and Lesbian Health Collective, a nonprofit organization dedicated to providing health services, advocacy, education to individuals of diverse identities. So with that, Linda Estabrook, thank you so much for making time for us today.
Hi, good morning, everyone. Thanks for letting me be part of this important opportunity to share some information regarding monkeypox and our community need, and nice to see various DPH colleagues participating too. We've communicated a lot recently. As is mentioned, I'm the executive, Linda Estabrook, the executive director of the Hartford Gay and Lesbian Health Collective. The Health Collective has provided services to the LGBTQ community since 1983, and we are also one of the legislatively required members of the statewide LGBTQ+ Health and Human Services Network. So here we are, monkeypox. What do we need now? And I really mean now, as in today. We need a deluge of money to drench this health emergency called monkeypox. We cannot keep doing this piecemeal. DPH has been doing a phenomenal job working to stay on top of this. But I know I can't speak for them, but I think that they could use some more resources too. We can't keep expecting the agencies and healthcare organizations that have stepped up to address this problem to keep doing what we're doing without providing the resources needed to really make an impact. Can you imagine what $1 million could do, what $2 million could do, what $10 million could do? Are any of the entities getting paid anything? I really don't know. I don't know if the hospitals are getting paid to store and distribute vaccine. I don't know if any vaccine administration agencies are getting paid. I know we're not getting monkeypox specific funding from the state at this time. At the Health Collective, we have redirected agency staff resources to monkeypox. I'm sure that that's how a lot of agencies have been approaching this. Our small agency has increased our clinic visits fourfold. We have increased our staffing by almost 40%. We doubled the amount of clinic hours. We have put out requests for funding to cover these costs, hoping that some of the funding requests are fulfilled. We have not waited for the funding. We have done what needed to happen in the immediacy of the moment. More funding money can be used for advertising on dating apps like Grindr and Scruff. Money can be used to boost social media posts. It can buy full page ads in print applications in gay resort areas like P-Town and Ogunquit. Funds can be used to contract with a design communication firm to develop messaging products, including digital ads for display in our organizations and in gay bars. I know I can speak for my staff, and I know for other LGBTQ plus organizations that we would be glad to offer our services, information, guidance, 2 cents on putting together various messages and getting them out there. Funds are needed to pay for increased staffing and redeployed staffing of vaccine providers and agencies serving the LGBT community. The state has a surplus of money. It has a significantly funded rainy day fund, and it's raining. We need to use the resources that we have available to take action on monkeypox. Broader, wider, bigger. And as I said earlier, and now. Many of the actions that I've mentioned have been taken by the Health Collective, by other organizations, but there needs to be more of everything. One of the things that I have asked for regarding the DPH website is I understand that there's required information that DPH needs to put on the website, but adding a little bit more and easier and direct messaging on the website, for example, regarding vaccines and their effectiveness and the amount of time it takes to be effective, and putting it right at the front of the page and in big, even colorful letters about what the vaccine is and what the vaccine isn't. And this request comes from a place of what we're hearing from people in the community. We have put together some very simple messages and direct messages on our website. One is fact: the monkeypox vaccine Jynneos requires 2 shots and takes a total of 6 weeks to be fully effective. Jynneos will not protect you immediately. You can't get it today and be safe for your trip to P-Town or a club night or a party night. Prevention is still the best way to avoid getting monkeypox. And the reason that we have these messages is because we have heard from people that say, I'll get the vaccine and then I'm fine. That this information needs to be out there. I also urge DPH to convene regular meetings with all of the vaccine providers in Connecticut. Even a 1-hour meeting each week can help to make vaccine delivery more consistent. There have been multiple instances of different interpretations of DPH guidance. I urge DPH to adopt the steps for all of the sites that we're using at the Health Collective for administering vaccine, doing a thorough eligibility screening to schedule vaccine appointments, having clients complete a vaccine consent form. Our form includes patient acknowledgement statements that include prevention behavior language and vaccine effectiveness language. Providing vaccine effectiveness flyers also happens after the client receives the vaccine. We started to implement follow-up calls, but we've done that only on a very limited basis because of limited capacity. And all of the messaging around monkeypox needs to go well beyond vaccine. Prevention, avoidance, harm reduction messaging needs to happen concurrent with any vaccine messaging. And lastly, and definitely not the least important, is security. We know that there's anti-gay rhetoric out there. We know that there are lies out there regarding monkeypox transmission to kids. These are dangerous circumstances, especially for LGBTQ organizations. And we really need the state of Connecticut to take the lead to interrupt those very dangerous messages out there. thank you again for this opportunity to communicate some really important information of how this is impacting the community.
Thank you so much, Ms. Esterberg. Thank you for raising the issues and areas of opportunity. I'm sure we'll have a more in-depth conversation around this shortly. The next person on our list to speak is Dr. Asha Shah, with who's coming through the Connecticut Hospital Association. Dr. Shah is a board-certified infectious disease specialist. She's been working with Stamford Hospital Medical Group for the past 9 years, and she is internal medicine trained at the University of Pennsylvania with infectious disease fellowship at Columbia University Medical Center. Dr. Shah, welcome, and please go ahead.
Thank you. Thanks, Senator Anwar. I also want to thank Chairman Jonathan Steinberg for giving me this opportunity today. So I have been asked to come and kind of relay our healthcare system's response to this outbreak. And what I can say is that, at the outset of this, the current outbreak 3 months ago, it's been a situation we've been watching very closely on the ground. And very reminiscent of the early days of the COVID pandemic in the spring of 2020, when we saw New York City really explode with cases, and then soon after Fairfield County felt a huge impact of COVID-19. So very early on in May, we put a plan together, a response plan, and actually Lynn Sosa, I remember her words very clearly, said, put a plan together now. And that's exactly what we did at the hospital. So our approach was to create easy to use algorithms for our clinical teams, initially in our emergency room, meeting with them, as well as our ID physicians, and our microbiology lab and our core lab, because we felt that those were the individuals that were going to be our first responders in the beginning of this to see potential cases and diagnose cases. We also slowly rolled out that education to the rest of our inpatient clinical teams, our nursing staff, and the rest of the clinicians that would potentially take care of these patients, as we started to learn that, yes, while the mortality is low, there is a significant amount of morbidity associated with this disease, and patients are being admitted to hospitals and requiring inpatient care. We also included education for our environmental services teams. We huddled with them on a regular basis to teach them how to properly handle linens and beddings to decrease any potential exposure that they may have. So that was the initial phase of our response. And then as things progressed in the state, we then moved to expand our education to our all of our medical staff in our healthcare network, and particularly aimed at primary care physicians and those that we identified that would be frontline clinicians in the community that would potentially be seeing these patients. So we moved from a model of, if you see monkeypox, call infectious diseases and send them to the emergency room, to, if you see monkeypox, this is how you can safely manage and handle these patients in an ambulatory setting. We've equipped all of our primary care offices with testing supplies, PPE, as well as testing algorithms and instructions on how to properly diagnose these patients. We've armed them with multiple sessions of education on how to recognize the disease, how to talk to patients about the disease without using stigmatizing language, and also how to guide them on prevention. So while all that's happened, we've also worked very closely with the Department of Health and with CHA. And I think that the relationships that have been established through the pandemic over the past 2 years has really served us well in the state. There's very big a spirit of collaboration with all of the hospitals and my counterparts around the state, where we share information on a weekly basis and try to, figure out what other people are doing, what works well, what doesn't. So we worked with them to obtain vaccine for high-risk exposures for our employees. We've had to vaccinate a couple of employees so far, and that went very smoothly in conjunction with the Department of Health. And we've also created focused communication to our high-risk patients in our healthcare network and sent that out through our electronic portal system to give them information on where to receive PEP++ in the state and how to go about doing that. And then the advances and the improvements in obtaining TPOCs over the past couple of weeks have been great. So kudos to the state for organizing that. We are receiving TPOCs to our pharmacy actually today to be able to use for inpatient cases. So I just want to say that, I think things have gone well. The state's done a good job. I think what more can be done now is more access to vaccine. If we can get more Jynneos vaccine in the state, we would be able to expand the sites where it can be given, and perhaps, distribute it to more trusted partners. For example, infectious disease offices in various healthcare systems that potentially see plenty of HIV patients and patients who are considered high risk for acquiring this disease, and who would be more comfortable getting it with their regular provider rather than at one of these community health clinics. So that's all I have to say. Thank you.
Thank you so much. Thank you. And our final presenter is with the Connecticut State Medical Society is Dr. Virata, who's an associate professor in clinical internal medicine with the section of infectious disease at Yale School of Medicine. He is one of the infectious disease doctors at a clinic located at St. Raphael's campus, Yale New Haven Hospital, and has been dealing with the special populations. He's been part of the Mayor's Task Force on AIDS and Project Access New Haven. Dr. Virata, you're on.
Thank you. I'm just checking if you can hear me.
Very well.
Okay, thank you, Senator Anwar, for allowing me to give a little bit of information, at least from our perspective or my perspective. I'm here also representing the Connecticut State Medical Society. I am very pleased and sorry. Sorry about that. I am wanting to share a little bit of my experience actually having dealt with individuals who actually contracted monkeypox. And again, also want to commend the state for their rapid response and also responding to requests that we provided when we actually first identified individuals who were exposed and needed post-exposure prophylaxis, and then moving on to actual patients who actually got monkeypox. A couple of them were admitted to the hospital, and the response there to getting access to the treatment. Can't emphasize enough that access to care and the treatments will help to stem this outbreak. And I will say that the process went very smoothly. We didn't have any major barriers in getting access to the treatments. I did want to point out there's something in the presentations and want to emphasize that monkeypox sort of can present the current outbreak presents quite differently from what people might think of that happened during the endemic or the endemic form of the disease that occurs mostly in Africa. And people here were presenting with lesions or areas that were involved that were not typical. And we quickly realized that we needed to work on trying to screen people for multiple diseases at the same time. So I do want to emphasize that sexual transmitted infection screening is an important part of taking care of the patient. In fact, in one of the studies that was published in the New England Journal of Medicine, they pointed out that 29% of their population actually were diagnosed with a concurrent STI at that time. Also want to point out that there are populations that are affected a bit. I mean, the emphasis in the beginning is the population that it was primarily men who have sex with men or other individuals in close contact with individuals with monkeypox. But in that same report that was published in the New England Journal of Medicine, they pointed out that 41% of individuals actually had HIV disease. I actually gave a little webinar recently sponsored by the New England AIDS training foundation that focused on the co-infection between HIV and monkeypox. I do also agree in all of the recommendations for harm reduction. Here at Yale New Haven Hospital, we've actually created a care pathway that addresses many of the different aspects, both whether you're dealing with someone with an exposure, potential exposure, or actual disease, and getting vaccines available to them. We've actually set up a vaccine clinic here at Yale New Haven Hospital. And also similar to our colleagues at Stanford Hospital, we have also notified a wide range of eligible patients through our electronic medical record system. And we've started to give vaccines. We've also started to, based on the recommendations, do intradermal vaccines that expanded the supply of vaccines to the eligible population. And I do have a request, as Dr. Sosa mentioned, that we're looking at additional methods of providing vaccines, and that we would probably need access, or at least the ability to receive training for individuals who are going to be providing or administering vaccines to the population, because it's a method that we haven't done in quite some time. And I think that's important to get people informed and educated about the proper technique for these vaccines. Finally, just want to mention that cases have been reported primarily in men who have sex with men. However, I do also want to mention that I've been asked a lot of whether or not this is sort of a new disease affecting gay men, and the epidemiology does point to that. However, monkeypox can actually infect anyone. I mean, anyone that gets exposed could be at risk of getting monkeypox. Has nothing to do with sexual orientation, gender. Anyone can get monkeypox. So I'm going to end it there and turn it over back to Senator Anwar. Thank you so much.
Thank you so much, Dr. Virata. Thank you, everyone who has been able to help us and give a little bit of insight into what is it that we are dealing with. I have a series of questions. I wanted to ask our team of the Public Health, Department of Public Health, a few questions. And I'll try to frame multiple questions and try to see if I can put them in front of you, and then you can probably address them. Look, we have a public health emergency. And then one of the rationale for the public health emergency is that there is a potential of this moving out of control. It is going to move in that direction. While the number 69 may not excite people, but these numbers can increase rapidly. We have seen this in New York, but this is very controllable. But if we have a federally designated public health emergency, that means there are federal funding that is going to be available. If we have the federal funds that are available, how are they going to get transferred over to the various organizations? For we just learned from Ms. Estabrook that we have a need for funding for education, and very targeted funding for education. So that's one area. How can we use it? What can the state do to be able to help this new emergency? We have created those pathways very well, and we know this. We've been using this for the past 2-3 years. The second part of the same conversation is that for the healthcare systems, is there an area of opportunity to try and expand that further? And I know the vaccines is very critical part of the puzzle right now, but do we have enough educational opportunities for the primary care physicians, who will be the first group that is going to interact? I know reading is not going to be enough. We need to have more conversations, discussions, collaboration, and case studies that we need to get towards that part. So is the DPH going to take that action as well from the clinicians' education? The other component, the third question I'm going to put forward is that, look, we have a challenge where people will be expected to isolate and not go to work and because of the risk of spread. Is the Department of Labor ready for the individuals who will not be able to go to work for small amount of time that they will be off? Is there systems in place? Are those collaborations happening at this time? And then another question that I've been getting is that very soon, many of the children in our state are going to go to various colleges. And many of the children from other states are going to come to our state for their education. It's been a week or so. There's going to be a lot of children in dormitories, boys and girls. I'm saying children because I'm older, but young people will be in the communities. We want to answer the question when towels are going to be shared, bed sheets are going to be there, the proximity starts to increase. Are we anticipating a bigger disaster and worsening of the spread, and what can be done right now, especially since we have limited options or limited number of vaccines that are available? And I'll stop here. And then let's go to the second group of questions in a bit. Anyone from Department of Public Health?
All right, thank you, Senator, for those questions. I will start, and Miriam can help me with some of these questions. So let me just start with the educational opportunities. So since we learned about monkeypox, we have been reaching out to the providers that we knew were going to be likely to potentially see and diagnose patients with monkeypox. So that included our STD clinics and included Planned Parenthood, making sure that people knew how to test, and making sure they had the supplies. So this has expanded to include in at least every other week and sometimes weekly healthcare provider memo, which goes to all licensed MDs, APRNs, PAs, to make sure that people have the latest information, whether it's about testing, whether it's about treatment or about vaccine. And so we have been doing that throughout, in addition to having at least, I think, 2 healthcare webinars. That said, I totally appreciate what you're saying. There's a lot of people that we want to make sure are aware of monkeypox, because just like any other disease, and as Dr. Virata said, this, especially an early rash or this rash in a part of the body that someone might not be expecting, can be mistaken for another disease, and then we're losing the opportunity to actually test somebody for monkeypox. So in addition, because, and I will say, we are definitely capitalizing on the relationships we have from COVID. We have created a lot of relationships with urgent care centers and other healthcare providers. And so because we already have those relationships, we're able to, reach out to people directly. They're reaching out to us and able to have those specific discussions. I think we all agree there's always more opportunity for education, and we are convening an internal committee on communications, not just for healthcare providers, but in general. And I think this goes to what Linda was talking about in terms of making sure that we have the best communication for the public and for persons who are at risk as well. So trying to make sure that we have and I'm sorry, I'm not thinking of the right word, but an organized communication strategy for all of the stakeholders that we're trying to communicate with. So in that vein, let me address your concerns about colleges and schools. So certainly, yes, we've already had several colleges reach out to us about making sure that they have kind of know how to refer their students who might be eligible for vaccine, and making sure that they know that process, as well as process for testing. So again, because of COVID, we have a very strong relationship with the colleges and universities in the state, so are able to have those individual conversations, as well as this Friday, I will be talking with them specifically to kind of basically give them exactly what we just presented here, and making sure that they especially have a plan for testing. I think that's really the most important thing, but as well as prevention messaging, and then making sure they know how to get vaccine for persons that might be eligible in their setting. In regards to the K through 12 setting, we are expecting CDC to release guidance specifically for K through 12 and early childhood. I saw an early draft last week, and I'm hoping that we will see that by the end of the week. And then we'll be communicating that. Again, we have a strong relationship with the Department of Education. They've been great partners throughout COVID, and in terms of regular communication with schools and superintendents. And so I think we would be able to utilize that same communication method there for information regarding monkeypox. To your question about the long isolation period for persons with monkeypox, it is definitely something we have been concerned about since the beginning of monkeypox, because this is a place where it is definitely different than COVID. So for COVID-19, we have a very specified time period. We can give people very specific parameters, and they're pretty clear cut. Unfortunately, with monkeypox, we have a situation where some people might take longer or shorter to recover. And a lot of it has to do with kind of their underlying medical condition, how many lesions they have, the location of those lesions, and then understanding that sometimes a lesion might be in a location of the body that is kind of hard to tell whether it's healing or not. So this is definitely a challenging situation. We have reached out to our other state partners to kind of talk about what the resources are that are available. Again, because of COVID, local health departments are very familiar with the resources that are available for persons in their community. And I think that's really the front and first line for people who have cases. They will be interacting with their local health departments from the beginning of diagnosis. Local health departments are responsible for interviewing them, for getting understanding their context, so those persons can be referred for vaccine. And we'll be continuing to touch base with them and monitor them throughout the course of their illness. So that's going to be their first level. I think what we're really focused on at the state level in particular is that if somebody had an urgent housing situation, and knowing kind of what we would be able to offer, what the resources would be for that situation. So that is something that we are working on. And then finally, in terms to your question about the availability of federal funds, so far, no specific monkeypox funds have been allocated. So there have been no additional funds allocated. The federal government has very slowly given us guidance on how existing funds could be used and the requirements around those funds. And so what we have done is, as we get that guidance, trying to make sure that, for example, for the staff that are working on monkeypox, making sure that we are accounting for that with the federal government, so that they know that certain staff that are funded on one thing are actually doing monkeypox, and making sure that we are within the confines of the grant in that sense. But I know that other work is ongoing to make sure that there are funds available specifically for monkeypox, and then having additional conversations about how additional funds could potentially be used. And I don't know, Miriam, if you want to add anything to that.
No, I think you summarized it well, Lynn. The only thing I would add is that, if and when federal funds are available, we will work quickly to start contracting with clinics to provide assistance, and we'll work quickly to identify the best resources. So I think, that's the type of planning that we can do now, so that if and when resources are available, we can be ready to hit the ground running.
Thank you for that. I just wanted to follow up with some questions. In your eligibility criteria, you've talked about jurisdiction, that under certain jurisdiction. I wanted you to clarify what that jurisdiction means for the eligibility for the vaccines. And also, if any one of the clinicians, the physicians in the conversation, if they can elaborate the fact that the vaccine is live, but at the same time, this virus is not going to replicate. If this is given, and because of the theoretically immunocompromised population having co-infection, what is the way forward? And around the clinical term, I also wanted to ask if we have not talked about the immunoglobulin use with vaccinia immunoglobulin in any of the conversation. In the past, we have had some of those options on the table. Then I have a third series of questions, but before that, one more thing on the financial component. We have funding in the state, and this is the time to be ahead of the curve, as Ms. Estabrook has said, that if we can expand the educational and targeted educational effort right now, we may be able to reduce the future expenses that we may have in this entire effort, and that's the critical part. I think. I know education was a critical part of COVID, but mask and isolation were part of it as well from a prevention point of view. For this one, education is going to be a far bigger part of a preventive strategy. And I'll wear my hat of a physician for a second. I am not fully satisfied with the amount of educational efforts that are going out at this time. So I'll make that statement, but if anybody wants to reflect from the public health first and any of the clinicians. Thank you.
Sure. Thank you, Senator. So in regards to eligibility for vaccine, the focus right now is for the doses we have in Connecticut, they are for Connecticut residents. So that is what I was referring to. Certainly, we know that our states that have gotten a lot more vaccine than we have been allocated have been able to expand their eligibility criteria. And that's why we've had some Connecticut residents be vaccinated in other states. But right now in Connecticut, for the doses we've been allocated, we are only allowing that to be used for Connecticut residents. In terms of the live vaccine, I'll just say that my understanding is that for the Jynneos vaccine, and I'm sure Dr. Shah, Dr. Prada can help me out here, Jynneos vaccine, it's a live vaccine, but has been made such that it is not replication viable, so it cannot replicate. That is different than the ACAM 2000 vaccine, which is why there's some different issues there, although I cannot say that I know the mechanism of that. And then to your question about treatment. So yes, the focus has been on TPOXX, especially I think because it is certainly in our experience and in general is actually very well tolerated and does come as oral and IV. So as an oral drug is really easy to give to patients. So that's, I think, why the focus has been on that drug. The Strategic National Stockpile through CDC does have access to at least one other antiviral as well as another, as well as I believe immunoglobulin. However, we have, and so we could request it. I don't know that we have had anybody in Connecticut who would need to have that. I think in general, the patients that have received TPOXX have responded quite well to it.
Thank you. Any of the physicians want to answer as well?
So I can just mention that the other two options for treatment are cidofovir and brincidofovir. So cidofovir is an antiviral that we use to treat cytomegalovirus infection. And so that is something that most healthcare systems keep on stock, at least, especially systems that take care of transplant patients. But it's a very toxic drug. And so I agree with Dr. Sosa that because the access to TPOXX has been expanded and made more an easier process, I think that right now we're focusing our efforts on using that.
I'll just add to the comment. So about Jynneos and ACAM 2000. So Jynneos vaccine is a modified vaccinia virus. So it's vaccinia is part of the orthopox family, and they modify it so that it doesn't have the capacity, as Dr. Sosa said, to replicate within the body, but it does stimulate the immune system primarily to produce the antibodies. ACAM 2000 is actually a live vaccine that can replicate within the body. And so individuals who have compromised immune systems, it might start replicating within them and may cause things like disseminated disease. And so for individuals with compromised immune systems, we typically avoid live vaccines for that reason.
So which vaccine would you use for patients who have HIV, Dr. Barada? How would you prevent?
So currently our recommendation for individuals living with HIV is to receive the Jynneos vaccine. Unfortunately, there is not a lot of data in terms of efficacy right now. This is totally new to us, and it's sort of an area that we need to gather more data. Thankfully, this is an effort that's not only local within Connecticut, but it's a national and also international look at how well this vaccine can prevent monkeypox. Not only for the general population, but in specific populations like people living with HIV.
Thank you so much. And I just wanted to make a comment, and you can correct me with our folks at DPH. The vaccines are at no cost to the patients, and the TPOXX is at no cost to the patients. And there are no questions that are asked with respect to your background, your status, and so on. Is that a fair statement? Immigration status, I mean.
Sir, absolutely yes, on immigration status. So in terms of proving that you're a Connecticut resident, if someone does not have to have an ID, they have to have something with a Connecticut address on it. But we've instructed the clinics to be as flexible as possible in that regard. In terms of the vaccine itself, that is correct. There is no cost for the vaccine itself. Clinics can charge insurance and administration fee, but if someone does not have insurance, then that they should not be collecting a fee to administer the vaccine.
Okay. And in the series of questions I'm asking, I'm just going to ask our presenters and panelists to say, look, we are on CTN right now. We are also on YouTube. If you had the opportunity to talk to the potential patients or the high-risk individuals, including the young boys and girls who are going to be going to colleges in the next week or so, what is it that you would like to say to them about various aspects? Representative Steinberg, you are off mute. Can we mute? Yeah.
I'll jump in. I just want to, I think, we want to reiterate our vaccine eligibility. So if folks who are practicing the behaviors outlined in the eligibility should seek vaccine resources. And those resources are available on the on our Connecticut State Monkeypox website. And as Lynn mentioned, we're going to work with the colleges and universities to identify, to make sure that they have the resources they need for testing and vaccination as well. The other thing I would say is that we are working very hard to destigmatize the need for services related to monkeypox, and working to ensure we're working with partners like Linda and like other advocates in the LGBTQ+ community to make sure that DPH is representing the virus well and how it is being spread, and also making sure that resources are being made available. Part of this is our broader communication strategy that Lynn mentioned earlier. So I want to kind of piggyback on that, and then also respond to your comment, Senator Anwar, about wanting more communications. I think similar to the COVID pandemic, we were, our initial response is reactive, and now we're at a point where we can be less reactive and more proactive. And part of that is really developing a broader strategy around communication. So, and that's something that we're actively working on at DPH. And so to the extent, Senator Anwar, that you have, concerns that you'd like to be addressed through communications, we would want to hear those. But then also want to make sure that we're working with external partners to make sure that they have the resources that they need to accurately communicate about monkeypox, and the resources that are available through the Department of Public Health.
Thank you. Anybody else wants to weigh in to give a message to the general public about prevention strategies? This is the time to do so.
I would just add that I think this is also an opportunity for individuals who are at high risk that may not be on PrEP for HIV. And so that's a strategy we've used as well, because oftentimes these individuals who are at high risk for monkeypox are also high risk for acquiring HIV. And so referring them to clinics and physicians that prescribe PrEP, because as was mentioned before, we are seeing a lot of co-infections with other STIs in these individuals. And so focusing some of the efforts on that and educating them that there are other methods to preventing HIV out there as well, I think is an important message.
Thank you. Yes.
So this is Linda Estabrook again. Regarding messages to the community, possible message to college students. This may not be the time to experiment. Just delay your experimentation with life. Life will still be there in a few months. Avoid hookup apps. People, not the app itself, go ahead and look at the app itself, but avoid hooking up with the people that are on the apps. This is not about being sex negative. The Health Collective has never been in that place. It's about wanting people to stay healthy and be able to have healthy and fulfilling sexual lives going far into the future. And for today to avoid situations that one of our original messages is, if you can get close enough, if you're close enough to somebody to get syphilis or gonorrhea, you're close enough to get monkeypox. Just very, simple communications, but we need to have these messages be broadly available and consistent throughout the state. It's, I'm glad that we've created some messages and we've gotten them out there, but if you have 100 different entities creating 100 different messaging, there's inconsistency that can develop with that. Sometimes I imagine, billboards throughout the state, not that I'm saying we should do this with billboards, but if you imagine billboards throughout the state that have the exact same message, and no matter where you drove in the state, you saw that. I mean, you see billboards all the time with messages. We need to communicate in so many different ways and in so many different environments, and prevention is a really, really important message. And certainly getting the vaccine is part of that. Behavior modification is part of that. And it will be really good if and it's great that the hospitals have done what they've done to be able to treat people and take care of people. But it would be much better if people didn't land in the hospital in the first place. With this. And I think that we're still in a place where there can be an opportunity for this to not spread as fast. I don't think it's going to stop, but to be more manageable, and behavior change is one of the key parts of that. Thanks.
Thank you so much, Dr. Virata.
Yes, thank you. I do just want to support that, along with everything else that's been said. I think this is an opportunity to promote healthy health practices that are safe. And I've been asked several times to compare this both to COVID and the beginnings of the HIV epidemic. And really, again, to emphasize, like I said before, that monkeypox can affect anyone, and people should not have a false sense of security that they're not at risk of getting monkeypox. And compared to COVID, I think what we do have available is that the resources currently is that we can accommodate testing needs that has been greatly expanded since in a short span of time. Again, we do have available therapies that have been shown to be effective against monkeypox. So again, some targeted promotion and also risk reduction, and having a low threshold to access care in cases where they're not sure of whether or not they might be at risk or have been exposed and need to be tested.
Thank you so much. And we'll open it up to questions from my colleagues. And I see Senator Haskell. Senator Haskell.
Thank you so much, Mr. Chair. And thank you all for your time today. I'm sorry that I am not on camera. I'm on my phone, but I found this forum to be tremendously informative, and I really am grateful to Chairman Anwar and Chairman Steinberg for bringing us all together on this important topic. My first question is for the Department of Public Health, and that's has to do with vaccine eligibility guidelines differing from state to state. If I understood earlier, that's in large part due to the differing vaccine amounts than, say, our neighbors in New York. But as that changes, and hopefully as vaccine supplies become more available, will the Department of Public Health be putting a priority on making sure the guidelines are similar or identical state to state? Because I think one takeaway of mine from the COVID-19 pandemic was that differing guidelines across state borders, especially when you represent a community. So,
Will, I think we are losing your connection, but I think we got the gist of your question.
Yes.
To a border like mine creates a lot of confusion among
again, I don't know if you can hear me, Will. I think your connection was off, but we got the gist of your question. So I'll have
folks who want to get
I don't think you can hear me.
vaccinated and their families.
I think it's playing at a delay, but Lynn, if you want to go ahead and start answering the question, I think we're
Sure. So when we rolled out our PEP++ or expanded PEP strategy on August 1st, the criteria that we used was actually mirrored New York City's. And as I mentioned, as of today, we've updated the eligibility criteria. So it is, I believe it is more in line with actually what New York City is saying now, as well as Massachusetts, as well as what the CDC is saying. So that was definitely one of our goals in updating the criteria, is trying to align ourselves as much as possible with our surrounding states.
And then to get to your question, Senator Haskell, about vaccine availability, with the change in how the vaccine is administered, we have more doses available to us, which was an added level of comfort with regard to expanding, for changing the criteria as well.
Understood. Thank you so much for the answer. And I'm sorry for the connectivity issues on my end. If I get into a better zone, I may ask more questions. But for now, thank you so much for the time, Mr. Chair.
Thank you, Senator Haskell. Next is Representative Zupkis.
Thank you. Thank you so much for putting this together. I've learned some things. I did come on a little late, so I apologize if I'm asking something that you've already answered. With this vaccine, has the vaccine been around for a while, or is it like the COVID vaccine that has just, was just actually formulated for the virus or the COVID? Can you tell me a little bit about the monkeypox vaccine?
Sure. So I'm going to start, and I am sure Dr. Virata and Dr. Shaw can help me. But yes, so the Jynneos vaccine has actually been around for a long time. I cannot recall the exact date in which it was approved, but it actually had some ACIP recommendations as of 2019. So because it was really originally developed for smallpox. But because the smallpox virus is in the same family as monkeypox, that is why we can use it for monkeypox. And so really we wouldn't have vaccine available now if we did not already have a vaccine that had already been around, had been studied, and was available. So for that, I think we are all grateful that we have a vaccine so early in this outbreak.
I'll just add to that. And the earlier vaccine, the ACAM 2000, which was approved, it was approved by the FDA in 2007. And the Jynneos vaccine, which is a newer vaccine, was FDA approved for smallpox in 2019. So these are not like, Moderna or Pfizer vaccines that were developed because something was happening. They've been available. Jynneos was in the stockpile at the CDC, and sort of that was the issue around the rollout. in that the supply was limited based on what there was available in the stockpile.
Great,
And
thank
I would
you.
just add that I think part of the messaging to individuals that are at high risk and in general is just that this is not a new disease. This is not a new vaccine, to kind of help decrease any sort of vaccine hesitancy that's out there. And I think that's what's been most frustrating for us on the ground is that, this vaccine has been available, it's in the stockpile. And so we kind of wonder, why don't we have more of this now? Because this is not, something that they need to go back to the lab to create something new. It's been there. We just kind of need more of it.
Thank you for that. And so, and again, you may have already answered this. So because it's been around, so I'm assuming that monkeypox is similar to smallpox. And when did monkeypox come about? Did it just come about, or if anybody can answer that?
Sure. So I believe monkeypox was first discovered in the 1950s. It was first discovered in a monkey, which is why it's called monkeypox, but the reservoir is likely to be small mammals. This is actually a disease that has been endemic, meaning spreading in some countries of Western and Central Africa for decades. What's new about it now is that now we're seeing it in so many countries where monkeypox does not usually spread. And the mechanism by which we're seeing it spread, again, that close, intimate sexual contact, is also new.
Great, thank you. And my last question is, and I'm not sure who can answer it. We had talked a little bit about, money, because we always need money for all kinds of different things. And so one of my questions is, and I appreciate the education and getting the word out on all of these things. I always ask questions, no matter what committee, but we always kind of work on the surface of these things. And how do we get to the root of the problem? And how do we change kind of that part of it so it doesn't become a widespread pandemic? We certainly don't want another COVID of all of these things. And so, what y'all have all been talking about, does that get to kind of the cause, the root of all of these things? Because I'm a believer that if we can take care of that, then it will help us as we all go along, so these things don't become so huge and out of control. No, that's kind of a question. I don't know if anybody wants to. I would appreciate some kind of guidance or.
So I guess, are you asking about the root of the outbreak, or?
Well, just the whole, it's been around for a long time. Honestly, and maybe my ignorance is the first time I'm hearing of it, recently. And so I just, it hasn't been an epidemic since the 50s. It's just, to me, seems like it's gotten bigger and more widespread. So maybe that's not the case. And so I'm just wanting to make sure that we can curtail it, contain it, and it doesn't become any bigger. And putting things out on, in the media and those kinds of things obviously help, but how do we kind of take care of it? How do we stop it from becoming very widespread? How do we stop it from becoming something more? And we really get to whatever it is that really causes it and help to stop those kinds of things.
Sure, I can probably take a stab at this one quickly, and I think that's I'm glad you're asking this question because it's very relevant, and that's why we had the conversation. It's in the beginning of the conversation. Dr. Sosa had a very good and comprehensive presentation, and for people who are tuning in right now, like Representative Zupkus, who just tuned in just now, so who missed the initial part of the conversation, this is going to be on CTN. Watch this, you will understand this aspect. And also one of the challenges that many of the people have learned in the last 3 years is that we're traveling quite a bit across the different parts of the world. And this traveling is associated with spread of some of these infections as well. So what may have happened in one part of the world is spreading now to the other parts because we are traveling much more. So we have to become more vigilant, smarter in many aspects, and have these conversations for educational perspective. So I'm glad you asked that question. I see Senator Haskell, sorry, has another question, or he's in a better location.
Thanks so much, Mr. Chair. And here's hoping I'm in a much better location this time. Thank you to the Department of Public Health for their thoughtful answer to my last question. I just have two more, and I'll ask them together just for efficiency's sake. The first is Dr. Anwar asked a really important question earlier about quarantine periods being a little bit longer, a little bit more complicated than they were for COVID. And I'm wondering what sort of relationships the Department of Public Health has built with congregate housing of all sorts. I remember this was a major topic of conversation during the COVID-19 pandemic, making sure that those who are experiencing homelessness, survivors of domestic violence, have quarantine opportunities available to them. My second question is regarding college students who are in Connecticut. We are so lucky to have some amazing institutions of higher ed in this state. And during COVID-19, they were treated as Connecticut residents for the purpose of vaccination. You mentioned earlier that clinics are instructed to be as flexible as possible with regard to residency, but will college students who are in school in Connecticut be allowed to?
Yes, they will. And we've already instructed the clinics on that. And then in regards to your question on congregate housing, so that is, so I just want to say that so far we've been fortunate with our cases, to my knowledge, not needing that level of assistance. However, it is something that we've been concerned about and have been talking about for the last several weeks, including reaching out to our DEMIS colleagues in terms of what resources would be available potentially in regards to housing. I just want to clarify that we only are concerned about persons who are sick. So we're talking about isolation. There is no quarantine recommended for persons that have been exposed to monkeypox. So we're fortunate in that regard with this disease, but certainly recognize that people staying home for 2 to 4 weeks is going to be a challenge for folks. I will say that CDC has allowed some flexibility in the isolation guidance. While it is ideal for persons to stay home for the entirety of that period, if persons have no respiratory symptoms or fever, there is some flexibility for persons to return to some normal activities, depending on what kind of work they do and that type of thing. So I think we have some flexibility here. That said, this is an area that we are trying to make sure we know exactly what the resources are available.
Be vaccinated here? Understood. Thank you so much for that answer. And again, thank you for the time, Mr. Chair.
Thank you. Some of my colleagues are texting me as well with some questions. So I'm just going to ask a question for the LGBTQ Health and Human Services Network. How can you assist in the messaging, and do you have any contracts with any of our state agencies or something that you can help us out at this very critical time?
So there are member organizations throughout the state, Hartford, Norwalk, New Haven. And so we have relationships with other other organizations that aren't members of the network. And so we have a far reach. We, while there is some funding, it's very limited funding that's available right now, access to about $10,000 of funding that we're in the process of requesting from DPH. It's part of a larger pool of money that is for the work of the network. We're working to get that money and divide it between 3 organizations in the state to do some social media, other advertising, printing, information cards to put in the bars. So there is the network, and the organizations we're connected to is a really, really good resource to get the word out to the LGBTQ community. But definitely we could use more resources to do more work.
Excellent. One of the other questions that was asked of me is that this has been endemic in parts of Africa. And why has this been endemic over there? And why have we not used our resources to control the infection there? Maybe beyond our scope, but we are sort of making mistake we made during the pandemic, where we did not look at a global vision to control things, and everybody was hyper local, which as a state we have to be. But anybody wants intellectually to speak to that?
Yeah, I can certainly say that this is something that people are recognizing, that monkeypox was probably spreading kind of under the radar or without recognition before the current outbreak. And unfortunately, I think people are recognizing that this was a disease that we should have been paying more attention to on the global scale.
Good. So go ahead, Dr. Virata. You were.
I was just going to add that there are actually two different strains, and so the one that's more endemic is a different strain than the one that sort of started the outbreak. And the reports were coming from, like you mentioned before, areas that had never reported monkeypox, probably related to some type of travel, and then just continued to spread as individuals were returning back to like their home countries. So the original reports were starting out in areas like Spain and Portugal, and then the UK before the cases were reported in the United States. But it seems that this is one particular strain that's not, that is related, but not the endemic strain.
Excellent. And I see Representative Kennedy has a question, but before her question, if I may just ask a question, I just had somebody text me. Right now, people are going to use already on social media, people who have biases against the LGBTQ community. Now they feel that they have every right to take their gloves off with their biases that they have, and their inner hatred they're manifesting in different ways. What can we do as a society to try and prevent that from happening and keep the people focused on what's at hand?
I can start from an educational standpoint for the community is just what's been said earlier, is that this is a disease that can affect anyone. So it's not about sexual orientation. It's not about gender identity. It's not about who you're having sex with. What's more important more important to talk about is the degree of sexual activity. How many sexual partners are you having? And so I think the messaging needs to be that anybody can get this disease. This is not a disease that's only affecting the gay community or the LGBTQ plus community. Even though that's what we're seeing now, anybody can get it. And so I think using language like that to not to stigmatize these groups, I think is a way that we can start from a healthcare provider standpoint. And I'll defer to others from the community standpoint.
So this is a struggle. This is difficult because you want to get the messages out to the people who are significantly impacted right now and get the vaccine out, get the prevention messages, get the prevention behaviors, have those continue to happen. So that this doesn't get bigger. And I know that people are very concerned, and I appreciate concern about stigma and discrimination against LGBTQ individuals. But at the same time, there's concern about making this like so broad that pretty much everybody ignores it. Potentially, and that's not a good thing too. And so just getting back to what I was saying earlier, is putting just a ton of resources behind communicating with the individuals that are currently impacted by this, and spreading monkeypox, or the potential to spread monkeypox, and providing really important, broad-based, but yet targeted information. One of the concerns, and we've been fielding a number of phone calls this week already, is, when talk started to, we're hearing more last week about, well, instead of one vial with one dose for one person for the vaccine, let's do 5. Well, part of the initial reaction is, oh, good, let's give the gay community less. That should work. And I know that sounds really sarcastic and awful, but that's part of the reaction. And then, this monkeypox is significantly affecting communities of color. And so while we do have a better understanding, a lot of us here, of how this could actually be a much improved version, not just a version of let's give people less vaccine so we can give out more vaccine. We need to give the right messages out to people, and the correct messages, that, what, there is information out there that this could be a much better way to actually get the vaccine, have it work well for you, and for us to be able to vaccinate more people. But people are getting in touch with us and saying, yeah, I'm not doing that. I'm not going to get less of a vaccine. I was going to get the vaccine, but now I'm not going to do that. And so it's that level of simple specificity of message that needs to get out there, again, consistently and broad-based and targeted just in a big way, again, now, not in a few weeks, okay, but now and yesterday. And as our medical director, who's an infectious disease physician, said to me over a month ago now, I feel like we're missing opportunities. And it's right. And I'm afraid that we're going to continue to miss more opportunities. There are people, all kinds of people that have rolled up their sleeves, and people at the Health Collective, people with the LGBT Health and Human Services Network, and we're ready to go. And we're already doing so much, and in some ways we're working way beyond capacity that we have right now. So there needs to be more capacity, and working with, if the state were to contract with a firm that has been successful with communicating public health messages in the state, contract with them now and have them develop messages and get the messages out there, get the messages to us so that we can disseminate them, find other creative ways to get the messages out. And putting messages on the Grinder and Scruff and those, it's not cheap. And entities like us and even larger entities don't have the financial resources to pay $1,500, $3,000 or whatever. The state has those resources, and the state should back this up, and not just with federal resources that are supporting what the state health department is doing, but with state resources to support what the community is doing.
Thank you. Thank you so much for that. And Representative Kennedy, you're next. Thank you for your patience.
Thank you, Mr. Chairman, and I do appreciate each and every one of you. We are going on nearly 2 hours, so I do appreciate all you've said. I just want to go back to Ms. Estabrook. I mean, the messaging is huge, and we talked about it earlier. All these kids that are going to college, especially the freshmen, they're ready to let loose. I envision that when they arrive, they get a freshman packet, so to speak. And wouldn't it be great if there could be some kind of informational in their packaging for their first week of freshman year or freshman orientation? But on that same note, is it Dr. Verada? He had mentioned when he was talking about this being an endemic in many countries prior to, we're going to be seeing our college students, they'll be studying abroad. So it's important they have all the information. So again, going back to Miss Estabrook, the messaging is so huge. So I really was more of a comment than a question, and to thank each and every one of you. And I hope we truly can, Miss Estabrook, as you were saying, finding that concise message that can get out there, and that there is no discrimination to anyone, there is no stigmatism, but making sure that, this could happen to you and not, it's not going to happen to me. So that's really important to me. And Dr. Verada, when you had said, the other countries, again, students that are going off to study abroad, we will be concerned they're going abroad. There could be something going on there, and they bring it back to the United States. So I appreciate everything. I appreciate that you're able to share your slides with us. Dr. Sosa, thank you so very much. And those were really just my comments. And I look forward to see how we're moving forward with our higher education and making sure that they are our local colleges, community colleges, and state colleges are involved. So thank you, Mr. Chairman, for your time.
Thank you. And seeing no other questions, I just wanted to thank each and everyone who has been listening, but more importantly, the people who have participated. Dr. Sosa, Miriam Miller, Jamie Krenitsky, Sydney Jones, working under the leadership of Commissioner Manisha Jutani and our governor. Thank you, Department of Public Health, for not willing to take a break. And we have not even touched on polio, but we don't want to have that conversation. It's almost like I want to see you and smile at a place and not have to talk about all of these areas. And Dr. Sosa, the backdrop that you have is phenomenal. It's like DPH killing all the viruses with a smile on your face. I love it. That's the DPH we know with all the work that you all do. I wanted to thank our other panelists, including Linda Estabrook. Thank you for your work under very difficult circumstances and important circumstances. And the vision, I wanted to recognize Representative Jeff Curry for his advocacy and work to try to think about the needs of all different communities, but specifically with the LGBTQ health and human services, the wisdom that he had put forward to be ahead of the curve, because having those relationships, having those state coordinated efforts gets us way ahead of many of the other states who don't even know how to handle this or begin to have even a conversation. So we are having meaningful conversations because of the work that has already been done by our state. And the Connecticut Hospital Association, again, another group that never gets a break and never gets paid enough for the work that they do. So thank you for the work that you're doing at so many levels. The hospitals came into existence for the most part when we had the first pandemic. And as the hospitals have been struggling, we see a big second pandemic that we have all experienced. And the only difference is after the first pandemic, everybody put their resources to create hospital systems to be the backbone of all our states and all our country. However, after this pandemic, the hospitals are still struggling, and that's the only difference. And I'm using the word after the pandemic, even though we are in the midst of it. It's the wishful thinking on my part, but still, we have to have strong systems. Without them, we cannot do this. And for Connecticut, with the Connecticut Hospital Association, Brian Cornoyer, Karen Buckley, and Dr. Shah, thank you so much for your work and what you're doing. And with the Connecticut State Medical Society, again, Dr. Virata and Mike Johnson, thank you for what you're doing. You're, again, the physician community, the healthcare personnel, they're here for rescue and part of the coordinated excellence in medicine, excellence in education, to try and be part of the solution. And for my colleagues who have been there, and above all, Representative Steinberg, who is at the forefront and advocate for health, public health, It's a blessing to be able to work with him. I sometimes would use the word I work under his guidance and his leadership. It's a blessing that we have such a committed chair of the Public Health Committee, the co-chair of the Public Health Committee that I'm able to work with. Representative Steinberg, I don't know if you have the opportunity quickly to say the final word. As I say that whenever there is an airplane, the co-pilot can take it, but the captain has to land the flight. So if you want to say the closing comments, if you're able to. As you know, Representative Steinberg is traveling, so and that's why he may be not in the position to have a conversation. So I'll land this plane. We will end this informational hearing, but the conversations will go on. Thank you so much, everyone.
Thank you, everyone. Thank you so much.
Thank you.